Those of you who read Circulation and Nature Communications will know about Professor Henggui Zhang, who is actually a professor of biological physics in the Manchester Physics Department. Henggui started off as a physicist, but has progressively come in bringing his rigorous methods into physiology, and is best known for putting together mathematically physiological data at the cellular all the way up to the whole heart level in the reconstruction of cardiac behavior and cardiac arrhythmias. We are very glad to have him here because he is at a critical stage of developing a virtual electrophysiological human heart. We are fortunate to get an early view of what he is up to in Manchester. So without further ado, may I welcome Professor Zhang and let him proceed with his description of his work.
Okay, thank you very much, Chris, for your nice introduction. It's my great honor to be here to talk about our work on the development of virtual human hearts. So this has been lasting for over 20 years now. So research activity in my lab mainly cover these two major lines here. The first line here is the develop large-scale virtual heart computer models. So this ranges from this single ion channel level to the whole cell. Then to bring in this anatomic structure to form the tissue and then the whole organ. And also we can put this heart inside this human torso to simulate this kind of electrical potentials on the body surface in the way to construct the ECGs and MCGs. So this is one line for this multi-scale computer models of the heart. Another line here, we combine this virtual heart with this 256 leads ECG vest. So in the way to combine these two to solve these inwards and forward problems. So we can measure this kind of a body surface potential from this 256 ECG. Then we can reconstruct this electric exciting pattern inside the heart in the way try to locate the origin of arrhythmias in the way to give this target kind of atrial fibrillation ablation. And also we can combine with this machine learning and also this artificial intelligence to develop an algorithm for automatic classification of ECGs. So this is the two major lines of this research activity going on inside of our lab. For the whole heart model, mainly we use this bottom-up approach kind of scheme. So we start from this kind of a single ion channel level. So in the way to put into together of this electrophysiological voltage climate data to form these mathematical equations to describe this kinetics of these ion channels. Then we can bring together of this tissue structure in the way for these fiber orientations. So cell-to-cell electric coupling in the way to form this tissue model. So then to bring in this anatomic structure into the model to develop this whole heart model. And of course, we can go even further to bring this patient data to form this patient-specific computer models for the heart. So this is from the single ion channel level to the tissue, to the whole organ, and then to the patient. We can also go downwards to consider the subcellular informations, such as this molecular information and the signal pathways to form this much more detailed kind of subcellular model put together with this single cell to the tissue and the whole heart models. So to construct these computer models of heart, we did several kind of essential components. This including this electrophysiology and anatomic structure. We also need to simulate this EC coupling. So in the way to form this biomechanics of the heart. Certainly there's another area, which is fluid dynamics inside the heart. So in our lab here, we mainly consider for the electrophysiology modeling, this anatomic modeling, and this EC and the biomechanical modeling. We are starting to do this fluid mechanics for the heart. So today I will give you a brief covering about these works we have done for this anatomical model reconstruction, then to the electrophysiology reconstruction. So then in the way to put them together to form the model for the whole heart. For the anatomical model, so the first anatomical model we developed for this whole heart model is based on this visible human project. Okay, so there you got a sequential of this slice of the human body. Okay, with a very high kind of spatial resolutions, about 330 micrometers. So there are two data sets here, one for male and one for female. For this one here, people use this kind of computer image processing algorithm to segment this heart. Then based on with this anatomical physiological information, then we can kind of reconstruct this 3D whole heart model with each color here to denote this distinctive regions of the heart. Each part of here got this kind of instinctive kind of electrophysiology. So, but this method got some limitations because the spatial resolution is still quite crude. In a way, we cannot extract these cardiac fiber orientations. In the cardiac tissue, cells are not randomly distributed. They are arranged and packed in such a way to form this kind of beautiful kind of fibers. These fibers form these cardiac conduction pathways. So this is really important kind of substrate for arrhythmia. So for the model to be realistic, we need to get these fiber orientations reconstructed from this anatomical model as well. So what we did here is recently we developed another way to use this micro CT to do fast and accurate scanning of the heart. So in this way, we can put this heart soft tissue in with this iodine. In the way we can use this kind of X-ray as a light source to get this heart scanned. So the spatial resolution can get to 10 micrometers. For some specific regions, we can even get this nanometer kind of spatial resolutions. So here, just to show you what we've done here, we got a very high fine spatial resolution cardiac images. Then we can use this kind of each of this image as a matrix. So in the way, we can use a mathematical way to extract this vector field for this kind of image. From there, we can calculate these eigenvalues. So in the way, we can reconstruct these fiber orientations inside this cardiac muscle. So here to show you the slice of the ventricle wedge we scanned and constructed. Here you can see this kind of a beautiful blood vessels. Then for the muscle here, you can see we can reconstruct to verify this kind of a structure of this cardiac fibers. This is the way we can use a very kind of a high throughput kind of a way to reconstruct this anatomic structure of the heart. The other part here is to reconstruct this electrophysiology. So mainly we try to put this external data for this from support clamp about the ion channels into a series of mathematical equations. So in the way from the models from single ion channel to the whole heart. So for the heart, it is really complex. So it is really kind of a heterogeneous tissue with the cells in the different regions have a different kind of a physical properties such as the length and the radius, and also got a different kind of morphology. Each of these morphologies serves their purposes. So this is from physically that got a different length, different radius, and also different morphology. Electrophysiologically, different cell types also got a different electrophysiological properties in terms of these ion channels. To work with Professor Mark Boyd in Manchester, we mapped this electrophysiology properties of this sodium channel, L-type calcium channel, and this IF channel for this depolarizing currents for different cells, such as this synaptic node, this atrial muscle, AV node, protein fiber, and then endosurface, middle layer, and episurface of the ventricle cell. You can see for all these depolarizing currents for sodium, calcium, and IF here, different cell types got different current densities. So this dot with a bar here to show external data. So this red solid line here is the value we used for constructing these mathematical models. So not only for this depolarizing currents show this heterogeneity, then for this repolarizing currents such as IKR, IKS, ITO, and IK1, they also have this different current densities for different cell types across the whole heart. So put this information together, so we construct up to 16 different cell types, okay, such as the synovial node mathematical model, simulating this spontaneous pacemaking of the synovial node cells for the center and the peripheral, and also this atrial muscle, then 3 different types of this atrial ventricular nodes, and this Purkinje fiber, and also 3 different cells from 3 different regions of the endo, middle layer, and episurface. So these are the mathematical simulated action potentials. These are these kind of expanded recordings. You can see these simulated action potentials show quite similar characteristics to these expanded recordings. Then with this single cell here, we have published for different regions of the single cells, ranging from synovial node, atrial muscle, this AV node, Purkinje fiber, and also left ventricle. So far, we published the 16 different cell types for the rabbit and the dog. So then similar work has been done for the human as well. For the human, we also published a series of models for specific kind of cell types, such as synovial node, atrial muscle, atrial ventricular node, Purkinje fiber, and ventricular muscles. Put this together with this anatomical structure, we can simulate this initiation and propagation of these action potentials. Slow this synovial node towards this atrial muscle, then towards this kind of ventricles. So you can see this tree structure here is this Purkinje fiber networks. We can also put this whole heart inside this human torso. In the way, when electrical action potential propagates in the heart, you generate this electrical field on the body surface. From here, we can register this electrical potential. From certain points here, we can simulate the ECGs. So here to show this similar P wave, QRS, and the T waves here. So this is similar kind of ECG show very similar kind of characteristics as experimental recordings, such as this PR interval, QRS interval, QT interval, and the RR intervals. To validate this model, we can validate at different levels. The model we developed for single ion channels, we validated there for comparing our simulation with the voltage clamp data. Then similar thing we can do for this single cell. Then for the whole heart, what we validate here is to try to compare the simulation of the ECGs from multi-electrodes on the body surface together with this experimental data obtained from the human body. So this is in collaboration with our colleagues in Newcastle that developed these multi-electrodes on the body surface. In a way, we can compare our simulation with these experimental recordings. So first of all, we can validate this human atrial model. So what we got now, we got this atrial geometry with different regions as shown here for the different cell types. So in a way, we can put this into human body. So then we can put these electrodes on the body surface here. So we can simulate this multi-electrodes ECGs. Here to show you this 30 leads, simulated P waves, compare with this experiment data. So the red line here is the simulation data. This blue line here is the experiment data. With the green line here to show this recorded ECG data from different subjects. You can see electrodes put in the front of the body, back of the body. Our simulation data fits very well with experimental recordings. Similarly, we can do this kind of ventricle validation as well. So this for ventricle cell type, ventricle geometry, fibrillation. We'll put this into the human body. We put the electrode on the body surface here. We can simulate the electrical field. From here, we can simulate the ECG. We can also simulate this magnetic field, which is MCG. MCG actually could be useful, show much better kind of advantage than ECG for diagnosis cardiac arrhythmias, because MCG doesn't decay when they are propagated inside the body. So this is something I believe should be a future trend for further applications. So this is to show you here, we simulated multi-leads of this ventricle ECG signals. Okay, so this experimental data shown with this red line, this simulation data show this blue line here. So with the simulated multi-lead ECG, with the simulator of this MCG, our simulation data fits well with this experimental data as well. So this gives us the validation. So in that way, we can have a three-dimensional kind of virtual heart. So this virtual heart could be kind of useful for investigate some kind of fundamental questions, such as what would be the mechanisms underlying the initiation and the termination of cardiac arrhythmia. Okay, so this will form this what we call e-cardiology. And also could be applicable to drug screen. In the way we can use these computer models to see what would be the effect and impact of these anti-arrhythmic drugs, whether or not they got kind of side effects. So certainly we can also use this virtual heart to do this for the teaching purposes for this virtual surgery. So this could be some potential applications for this virtual heart. Today, what I'm going to show you, the work we have done to use these computer models to investigate this kind of atrial fibrillation, what would be the mechanisms underlying this atrial fibrillation, because atrial fibrillation. Especially, we try to use the computer model to elucidate this role of this ion channel remodeling to see each of which contribute to this arrhythmogenesis. So atrial fibrillation, as you know, is a very common cardiac arrhythmia. So it's got a very kind of special features, such as rapid and erratic electric excitation. So in the way, this causes this atria to lose its power to pump the blood. It's got a very high incidence for aged people, especially with age over 65. There's bigger than more than 2% of this incidence. So possible factors for this atrial fibrillation include aging, cardiac structure kind of disruption, genetic kind of defects, and also hypertension, and also this atrial fibrillation begets of atrial fibrillation. So experimental data from animal study to show here, atrial fibrillation or atrial tachycardia can cause these electrical remodelings. So first of all, this remodeling includes ion channels, which got this downregulation of the L-type calcium channel, and also this potassium channel and the sodium channel, which leading to this abbreviated or shortened action potential duration. So then the second kind of remodeling here is the gap junction remodeling, which disrupt this especially kind of a coupling between cells. Okay, so then also it can cause impaired this calcium handling. All of this can might contribute to this shortened wavelength of these excitation waves in a way to let this limited atrial mass to sustain this multiple electrical excitation inside this kind of atria in a way to sustain this atrial fibrillation. So this is kind of experimental data from animal studies to suggest this is the pathways for this pro-arrhythmic effect of this atrial fibrillation. Okay, but certainly the data from human also show similar kind of atrial fibrillation remodeling. So this slides show the work from this Bosch et al. Study to show this recorded action potential of atrial myocytes from patients with a normal sinus rhythm and with a persistent atrial fibrillation. You can see this action potential recorded from the persistent atrial fibrillation patients got a very shorter action potential duration as compared to the data from this patient with a sinus rhythm. So this also have this kind of atrial fibrillation, this action potential lost their rate dependency. So this is the kind of recorded action potentials. So these changes in the action potentials are actually associated with changes in the ion channels. Okay, so Bosch et al. Also show this kind of a downregulation of this L-type calcium channel, then this downregulation of the ITO, but this upregulation of this IK1. So that's data from this kind of ion channel level seems to suggest there's kind of a kind of ion channel mechanism underlying this abbreviated action potentials. An independent study from Workman from Glasgow shows similar kind of atrial fibrillation induced electrical remodeling. So they also show this downregulation of L-type calcium channel, then this potassium channel for the ITO, but upregulation of the IK1, but just come up to different kind of levels. So then following on this, there's many studies to look into this atrial fibrillation-induced remodeling for various ion channels, including L-type column channel, IKUR, which is atrial-specific channel, then ITO, IK1, IKS, then this calcium exchange as well. So different labs seems got different kind of variations of this electrical remodeling. So in a way, in order to put all this data together, we can use consider 4 different scenarios, which is atrial fibrillation 1, atrial fibrillation 2, atrial fibrillation 3, and atrial fibrillation 4. Atrial fibrillation 1 is based on the data from Bosch et al. Then atrial fibrillation 2 is based on this Workman et al. Atrial fibrillation 3 was from Wagner et al. Atrial fibrillation 4, we consider the case when everything were considered in together. Okay, so then the question here is experimental studies have identified this ion channel remodelings. What we would like to ask here is, first question is this kind of atrial fibrillation-induced ion channel remodeling sufficient to account for the change in the human atrial action potentials? So this is the first question we would like to ask. If they do, then the second question we would like to ask here is, since so many ion channels involved, what would be the primary factors among this remodeled ion channel contribute to this atrial action potential duration abbreviation? Is it either downregulation of this L-type column channel or upregulation of this IK1? So then the third question here is, how does this atrial fibrillation-induced ion channel remodeling helps to sustain this regime which underline this atrial fibrillation? Then this next question we would like to ask here, how does this atrial fibrillation-induced ion channel remodeling helps to increase tissue's susceptibility to initiation of this atrial fibrillation, not only to sustain maintenance, but also for the initiation as well? To answer these questions, we use these multi-physics modeling approaches. So to answer the first question here is ion channel remodeling sufficient to account for this atrial APD abbreviation? What we did here, we use 2 different cell models of the human atrial myocytes. One is the Ligon et al., one is the Componets et al. So then we consider 2 cases here, AF1 and AF2. What we show here, either we use the AF data from Bosch et al. Or from Workman et al. Our similar action potential show this atrial fibrillation can cause very short action potential durations for both models, for both kind of data sets. Then we consider further AF2, AF3 to AF4. We show all these atrial fibrillation models with different data sets considered. There's a kind of a dramatic APD shortening. Okay, so there's one case here. So the data from Wagner et al. Show this IKUR is downregulated. So because IKUR is atrial-specific repolarizing currents, so this downregulation can cause a bit of a kind of a prolonged action potential as compared to when this other ion channel remodeling was considered. It causes this kind of atrial APD abbreviation. It can also cause this reduced kind of cosmic transient kind of amplitudes. Okay, so this can also cause this kind of a reduction in the upstroke velocity. So in that way can reduce this kind of a conduction inside the atrial tissue. It also show, the simulation also show this loss of the rate dependency of this APD. All seems to fit to this experimental data. So in this way, we say, yes, so this ion channel remodeling are sufficient to account for this atrial APD abbreviation. So then the second question here is whether it's L-type cosmic channel downregulation or upregulation for IK1, which one played a major role relatively. So to see this question here, what we did in the mathematical modeling, we consider this IK1 upregulation from control from then to the maximum level the experiment that have shown. Then we also do another set of simulation to decrease L-type cosmic channel from this control to this maximal value of this experiment data. What we see here, this upregulation of IK1 seems to produce much more APD abbreviation as compared to the L-type cosmic channel. So in this way, we get a conclusion here. It's the upregulation of IK1 may play a predominant role for this APD abbreviation. So then the second question here, whether or not this kind of remodeling, electrical remodeling can help to sustain this kind of atrial fibrillation. In the way we use these 3D whole organ models. What we consider here with the 3D atrial model, we consider the control case with a normal atrial tissue, with this AF-remodeled tissue, with this IK1 upregulated only. What we can see here, for the control case, we can initiate the reentry, but this reentry terminates itself, somehow like a proximal atrial fibrillation after a while. But with this electrical remodeling, once this atrial fibrillation is initiated, there's multiple waves here. So this multiple wave sustain with the whole period of the simulation. When we consider this IK1 upregulation, so then this atrial fibrillation also sustained in our model. It is seems to suggest this IK1 not only can account for this APD upregulation, can also account for this maintenance of this atrial fibrillation. Similarly, another study has shown here. So there's KCNG2 genetic defects happened in some familiar atrial fibrillation patient. So this caused this gain function of IK1. So this simulation here seems to fit nice to this story about this KCNG2 gene mutation, which can help to pro-arrhythmic. So then the last question we would like to ask here, how does this atrial fibrillation induce the electromodeling? Helps to kind of initiate this kind of atrial fibrillation. To understand this question here, we try to use this three-dimensional model of the human atria. So in the way we can quantify this regional kind of heterogeneity, which is measured by this action potential durations in the local regions between kind of labeled cells. What we especially will look at two junctions. One junction is this left atria, the pulmonary vein. Another junction here is look at the crus-terminus pectoral muscle. Okay, so in the way we can characterize in the whole atria about this APD regional differences. There with the color to show this large APD differences here, so as compared to other regions. Then we can consider this APD differences for different scenarios. What we can see here, so this APD is abbreviated. People would assume this abbreviation of the APD would reduce this kind of a junctional heterogeneity. But what we show here, as compared to the control, even though this APD is abbreviated, but this delta APD at these junctions seems maintained. So that's still very dramatic. So then with this kind of a dramatic APD difference, kind of a regional differences, a premature kind of a stimulus can help to initiate conduction block, leading to this kind of a formation of this reentry as shown in here. Okay, so then in a way we can quantify this inducibility, what we call vulnerability window, within which time window within which as a kind of a premature stimulus can initiate either conduction block or initiate this reentry. We can consider this kind of different scenarios of atrial fibrillation data with the compared with the control. What we're showing here at its crus-terminus pectoral muscle, this atrial fibrillation induced remodeling can cause increase of this conduction block, okay, and also can produce this reentry. So then even more kind of a phenomena we can see at this left atria at the pulmonary vein junction. It seems that this atrial fibrillation induced electrical remodeling can help to kind of increase this vulnerability of this atrial tissue for the genesis of atrial fibrillation. So when we consider this IK-UR remodeling, we can see even a bigger increase in this conduction block time window and also reentry kind of a time window, which indicate this increased inducibility of atrial fibrillation by a premature kind of secondary stimulus. Then we use the model, we try to answer another very important clinical question here. So this is about this atrial stoning. After patient have this cardioversion, over years, quite often this atria still after successful cardioversion, this atria stand still. So that doesn't contract. So it may take 3 months for the atria to recover this contraction power. So then the question here is, what is the mechanism for the atria to be stand still? So in the way, how they lose the contraction after this cardioversion. So to look at here, we use these 3 different models. When it is a normal tissue, you can see this atria got this kind of a very powerful contraction. When we have this atrial fibrillation, you can see this atria more or less lost this kind of a contraction power. So there's a multi-waves propagating here. But in this case here, we look at this atria when you come back to this sinus rhythm, but with this remodeled tissue, you can see this kind of there's a normal excitation, but the atrial contraction is very weak. So now we look into the detail by look at this recorded action potentials from wind point from this 3D atrial muscle for this action potentials, then for the calcium transient, for this sarcolemma length shortening, and for the force generated by these cells here. You can see for the control, you got this enormous action potentials here with this very large of the calcium transient produce a very large cell shortening. So in the way produce a very significant of this kind of active force for contraction. But when you got this atrial fibrillation, you can see this electric action potential is becoming irregular. So this leading to this irregular calcium transient, then leading to this kind of abolish the kind of a sarcolemma shortening, then this activation force become flattened. Okay, but with this kind of atrial fibrillation remodeling after this kind of conversion, even though come back to this sinus rhythm here, you can see we got this action potential here, but then this action potential is very short. So in the way leading to a very reduced kind of calcium transient, this produce a very short kind of a smaller this cell kind of contraction, a very smaller kind of a contraction force. Then to look into the much into detail here, compare the control and this atrial fibrillation induced electrical remodeling, you can see there's a kind of a APD shortening. So this APD shortening leading to this reduced kind of calcium transient, leading to a reduced cell shortening, leading to a reduced kind of active force for the contraction. So in this way, it is kind of suggesting a new target for treating this atrial stunning after the cardioversion. So this is something maybe worry future studies. So this is about this kind of atrial fibrillation, begetting atrial fibrillation. Atrial fibrillation can also be associated with people with genetic defects. So especially for certain ion channels. So there are multiple ion channels have been identified to be defects due to this gene mutation in these patients with familial atrial fibrillation. So in our study here, so we look at a particular kind of ion channel, which is KV 1.5 IKUR. So this is a kind of atrial specific kind of a channel, so only exists in the atrial tissue here. So we look at how genetic defects in this channel casing and A5 here can be pro-arrhythmic. So our colleagues in Copenhagen, they identified about 6 different variants of this genetic mutation in this casing and A5. Okay, all these kind of cause this dysfunction in these IKUR channels. So these 6 different kind of variants happen in different regions that can have different kind of functions. So one function here is called gain function mutations. So these 3 different variants can cause this gain function of this IKUR. So this is data show from the culture cell here with these 3 genetic defects here. You can see this kind of mutation can cause this increase of this current density of this IKUR, which is associated with the leftward shift of this activation curve. Then there's another 3 here is associated with this loss function. So then this loss function is associated with this reduced current density, which is a kind of a rightward shift of these activations. So both loss function and the gain function of these genetic defects have been identified in the atrial fibrillation families. So the question here, how these 2 different kind of functionality kind of changes can help to kind of initiate and maintain atrial fibrillation. So this is something we want to ask here. So first of all, we look at this kind of a gain function mutation, how they would affect this action potential kind of potential durations. And also we look at this kind of a loss function here. Okay, so there's with this gain function, you got this APD shortened, but with the gain function, you got this APD kind of prolonged. So then the question here, how this gain function affect this reentry dynamics. So with this gain function here, you got this shortened APD action potentials. So this can help to sustain this atrial fibrillation when you simulate in the 3D atrial muscle. But for this loss function here, you can see with this variant, two variant here, this atrial fibrillation actually self-terminate after a little while. Yeah? So only in this case here, with this loss function P4886, you got the sustained atrial fibrillation. It seems to suggest that this gain function and the loss function may have a different pathway for this pro-arrhythmic effect. So in a way, we look at in detail. For this kind of a gain function we just said, this kind of is associated with this abbreviated action potential durations. So this is somehow kind of clear how this would be pro-arrhythmic. But for this gain function here, so we can see there's prolongation of the action potential. With this prolongation, when a combined action of this beta-adrenergic stimulation is considered here, with this loss function here, you can see there's a kind of EAD being produced. So this EAD is induced by this adrenergic stimulation. So in a way, when EAD is kind of induced, it can trigger this arrhythmiogenesis. So in this way, we can see this gain function and the loss function that may have different kind of pathway leading to even though the same consequence of atrial fibrillation. So then this is the part of work we've done for using the model to simulate, to investigate this kind of a cardiac arrhythmia. So then the second part I'm going to cover here to just briefly to see how this virtual heart model can help us to study these drug actions. The platform we set here to use this single cell model, tissue model, and whole organ model, then to integrate of this data from different kind of levels, such as, let's say, Paget clamp and also electron mapping. We put them together into the human heart model, so then we can simulate this kind of ECGs, especially we look at this QT interval. Drugs, if prolong this QT interval, has been regarded to be pro-arrhythmic. So this is something we want to look at to see whether we can identify some kind of this pro-arrhythmic or side effect of this some kind of drugs here. So that in this study here, we show these two different drugs. One is the cisapride, another is the amiodarone. Okay, so both drugs would prolong this action potential during the QTs. So this kind of drugs here are target kind of IKR. For this cisapride, for the amiodarone, it targets both IKR and A-type cosmic channel. So both drugs can produce a QT prolongation, but one drug is kind of very risky, has to be withdrawn from this clinical use. Another drugs like amiodarone, even though it's prolonged this action QT interval, but still safe for being using. So what we try to see here with these different drugs, with a different target for different ion channels, what would be the pro-arrhythmic effect of this cisapride? So what we found here with the kind of these two drugs with this kind of experiment data, we can simulate this QT prolongation for both this kind of low dose and high dose of this cisapride and this amiodarone. But certainly for this cisapride, when we have this control tissue here, we can initiate this kind of ventricular fibrillation. But when we apply this cisapride, so this drug seems doesn't terminate this kind of ventricular fibrillation. But with amiodarone, so even though, okay, so similar kind of effect for QT prolongation. But when we apply this application of amiodarone, you can see this ventricular fibrillation is being self-terminated. Then we look into the detail, what is the differences between this pro-arrhythmic effect of the cisapride and the amiodarone. Okay, so now we look at how these drugs affect this vulnerable window, which is inducibility of this arrhythmia inside in the tissue. When you look at here for this low dose of cisapride and high dose of cisapride and the low dose of the amiodarone and the high dose of amiodarone, what we found here, this kind of cisapride increase this vulnerability of the tissue very dramatically, while this kind of amiodarone can have just a modest kind of increase this tissue's kind of inducibility for ventricular fibrillation. Then, in a way, if we look at this cisapride, we can theoretically put another kind of action of this A-type cosmic channel blocking together with this actions of cisapride, you can see with this kind of a combined action here, so this inducibility is reduced even though you use a kind of a cisapride. So in this way, whether this suggests that multi-target would be more safer, okay, for treat this atrial fibrillation without this leading to synergetic kind of a pharmacology. So this is the question mark I would like to get help from you. So then recently we look also another study here with this azam, azithromycin, which have been used to be used in combination with kind of a hydrochloroquine for treat this COVID-19. But certainly there's a worry about this cardiac toxicity of this azam. So in the way we can try to use the computer model to see what would be the side effect of azam. So what we used here is to use the data from Zhang et al. To show this kind of azam action, which is targeted for sodium channel IKR, IKS, and also atopic channel and IK1, which can produce a downregulation of this ion channel, which are dose dependency. Okay, and also that kind of this drug accumulated in the bloodstream, which can cause this chronic kind of effects. What we look at here, try to see for this acute effect, what are the action of this azam would be. So use this 1D tissue model, what we found here. So this azam itself can reduce this kind of conduction velocity, can produce this kind of a QT interval, can also cause this kind of increase in the spatial heterogeneity. All this could be this kind of arrhythmia, pro-arrhythmic. And most importantly, it can increase this kind of a sodium kind of concentration, okay, cause this overloading of the sodium ions inside the kind of cardiac muscle. So this kind of overloading of the sodium can be arrhythmia, can be pro-arrhythmic. Okay, so to summarize here, or what to see here, for one study we done here with this atrial fibrillation-induced ion channel remodeling, it can cause this shortened kind of APD, which together with this slower conduction velocity, leading to this shortened wavelengths. And also it can increase the tissue kind of dispersion at the junctions, which can increase the tissue vulnerability for conduction block, leading to the formation of this re-entry. So this can cause this pro-arrhythmic effect for this atrial fibrillation remodeling tissue. Then for this kind of a genetic variance in KCNA5 mutations, with the gain function, with the loss function here, both can have different pathways. When leading to this shortened wavelength excitation, which perpetuates this fibrillation, atrial fibrillation. Another one with the loss function here, it can cause this EADs, especially with this isoproline stimulation. Okay, so in this way, it can also cause this conduction block, leading to this kind of great risk for this atrial fibrillation. So to summarize here, I would say we have developed a model of this heme heart, even though it's preliminary, but still it shows this promise for this application. Certainly a long way to go for develop a more realistic and accurate kind of human model heart, which can be used for kind of a drug screen. And also for this atrial fibrillation, the message here is mainly is the atrial IPD abbreviation caused by this electrical remodeling play a major role for this kind of atrial fibrillation initiation and maintenance. For the drug safety part here, we show here multi-drugs. The drugs targeting multi-ion channels may be safer than those targeting single ion channels. So, and also most importantly, azam should be cautiously used for COVID-19 patients. So last but not least, I would like to thank my collaborators. Okay, so especially Chris Huang, with working with this azam and HCQ recently, and also work with kind of my German colleagues like Gula Simon and Frank Sachers for this human model development, and my long-term collaborator, Professor Cliff Garrett for atrial fibrillation, and also Tony Workman and Professor John Hankins for this kind of a drug effect. Okay, thank you very much. I stop here.
Thank you very much.